All right, well, hello. My name's Lindsay, and this is Dana, and this is Brooklyn. And like Tammy said, our topic will be on non-tubal ectopic pregnancies. So to start off with, what is a ectopic pregnancy? And in its simplest form, an ectopic pregnancy is a gestational sac that implants outside of the endometrium. And it's very important to be able to diagnose ectopic pregnancies because they are one of the leading causes of maternal-related deaths. And we decided to focus on non-tubal ectopic pregnancies because they are often more challenging to diagnose and detected later on in a pregnancy and therefore are associated with higher mortality rates. And for our research, we ended up focusing on more current literature within about the past 5 years. And again, we focused that literature specifically on non-tubal ectopic pregnancies. Now, some common signs and symptoms to look out for if you have a patient who you're considering may have an ectopic. Some of the more common signs and symptoms include abdominal pain, vaginal bleeding, a positive pregnancy test, elevated beta levels, or amenorrhea. And some less common symptoms to look out for include nausea, constipation, diarrhea, and vomiting. Now, to look a little bit closer at the beta levels, if your patient has blood work and it comes back over 1,500 and there is no signs of an intrauterine pregnancy, that is a red flag that you should be considering an ectopic. Additionally, if your patient is having blood work done multiple times to watch the rate of the beta, an ectopic pregnancy will increase at a slower rate from a normal intrauterine pregnancy. Now, here we have a list of some risk factors associated with ectopic pregnancies. We'd just like you to note that the two most important risk factors include advanced maternal age as well as assisted reproductive technology.
Right, so currently what we know is with transvaginal ultrasound, you can diagnose tubal ectopics around 87 to 90% of the time. They most often present as a non-cystic adnexal mass in the picture there. You can see the ring of fire sign. It's the increased color Doppler flow around the mass. We also often see free fluid. The sonographic features of non-tubal ectopics are much less often missed. They're much more often missed, even on EV, so we would like to discuss the various types in the hopes that they will be better recognized and discovered earlier on in pregnancy, thereby decreasing maternal mortality. So the first type we'll be talking about here is interstitial ectopics. They occur when the implantation of the gestational sac occurs along the interstitial part of the fallopian tube. They make up around 2 to 4% of all ectopics. They are less likely to present with bleeding, as the pregnancy is still surrounded and contained by myometrium. Some things to look for: the pregnancy will look similar to an intrauterine pregnancy, but one side of the wall will measure less than 5 millimeters. The interstitial line sign is another feature where an echogenic line can be seen extending from the endometrial canal to the gestational sac, as you can see in the figure on the right there. The interstitial ectopics have the highest mortality risk than any other type of ectopic due to the close proximity of the arcuate and uterine vessels. The next type of ectopic we'll talk about here are ovarian. They are only about 0.5 to 3% of all ectopics. The main risk factor exclusively related to this kind of pregnancy is an intrauterine device, and this accounts for 57 to 90% of ovarian ectopics. The main sonographic feature is a gestational sac attached to the ovary near the cortex, corpus luteum, or follicles, as well as the presence of a yolk sac and fetal pole. In addition, a thick echogenic ring with an internal hypoechoic area, often larger than the ovary, is often seen. There will likely be a normal-appearing endometrium with no gestational sac present. A tubal ectopic can be differentiated from an ovarian EP by the sliding organ sign. This can be done when you apply pressure to the ovary. If you apply pressure, the mass will not move. So the last type I'll be talking about here is cervical ectopics. They present as less than 1% of all ectopics, gives the uterus a bit of an hourglass shape where the uterus is empty and the cervix balloons out and contains the gestational sac. The sac is seen at the level of the isthmus, below the internal os, and the endometrium will appear as a normal stripe. There's been a proven association between cervical EPs and the use of assisted reproductive technology. The sliding organ sign is another indicator here as well. For a cervical ectopic, when pressure is applied, it will not move, whereas an abortion in progress will. These are very important to diagnose, as the potential for hemorrhage can be life-threatening if a D&C is performed.
Okay, so the first I'll be talking about is cesarean scar ectopic. It's the most rare form of ectopic pregnancy and accounts for 6% of ectopic pregnancies in patients who have had prior C-sections. And this is on the rise because of the increase in patients using cesareans to deliver their babies. And it's when the gestational sac implants at the scar at the anterior isthmus. So at this image, it's the opposite of what we would see, kind of flipped from what we would see on ultrasound, but you can see the bladder on the left. So there's the anterior isthmus and the gestational sac implanted there. The sonographic appearance is an empty endometrium and an empty cervical canal. So in this image, you can see there's nothing in the cavity there, and a thin myometrium, which is pointed at by the yellow arrow, and between the bladder and the gestational sac. Next ectopic is abdominal, and it accounts for around 1% of all ectopic pregnancies. This is often misdiagnosed due to its low occurrence rate. It's when the gestational sac implants somewhere in the peritoneal cavity, and it can really be anywhere in the abdomen. For example, on abdominal organs, vessels, on the diaphragm, etc. The developing embryo will obtain its blood supply from wherever it implants. The sonographic appearance is a normal appearing endometrium without a pregnancy and a complex mass with a gestational sac elsewhere in the abdomen, wherever that may be. Heterotopic pregnancies account for 1 to 3% of ectopics, and it's when an intrauterine pregnancy occurs simultaneously with an ectopic. The sonographic appearance is a normal intrauterine pregnancy. As you can see on the left here, there is an intrauterine gestation within the uterus, as well as a complex adnexal mass with vascularity. In this example, it's on the right side of the screen, and it's clearly outside of the uterus. However, ectopics can be in any location. It's just considered heterotopic when it's simultaneous with an intrauterine pregnancy. Beta levels are an unreliable indicator. As we mentioned previously, ectopic pregnancies, the beta levels rise slower than a normal intrauterine pregnancy. So because there is a normal intrauterine pregnancy present, then the beta levels will appear normal, which can be a little bit misleading. Pitfalls and limitations: a pseudogestational sac within the endometrium during an ectopic. It can appear like a normal early intrauterine pregnancy. A cesarean scar EP can be misdiagnosed as a Nabothian cyst or a failing pregnancy on its way out. If you do think it's a failing pregnancy, make sure you think of the other features that would go along with it, such as retained products, decreased blood flow, and an opening internal os. Around 1% of ectopics present with a negative pregnancy test, so don't use a pregnancy test as the only indicator of an ectopic. And mirror image artifact. It can mimic a heterotopic pregnancy in this image here. On the left, it's an intrauterine pregnancy, and then there's a strong reflector, and on the right, it's an artifact. So that strong reflector is mirroring that true, real intrauterine pregnancy. It could look like a twin pregnancy.
All right, so we would like to end this presentation with an interesting case study. And in this case study, there was a 31-year-old female. She'd had no period for 40 days and a distended abdomen for 27 days. She went to her local hospital, and the doctor ordered a CT, which discovered an incidental mass in her liver. She also had blood work done, which came back with HCG levels just under 50,000. She was also ordered to have an ultrasound, and with the ultrasound, they didn't find any evidence of an intrauterine pregnancy. So they also assessed the liver, and there they found a 5-centimeter hyperechoic mass, which correlated with the findings of the CT. The liver was dissected and sent to the lab, and it was confirmed to be an ectopic. And this patient had routine follow-up appointments and made a full recovery. A case study is like this to show the importance of collecting all your clinical information and to reiterate that an ectopic pregnancy can be somewhere you least expect it.
So in conclusion, it's important to accurately identify an ectopic and determine where it's located. If your patient is having symptoms of an ectopic, like bleeding, palpable adnexal mass, or abdominal pain, scan where it hurts. And even if you do see an intrauterine pregnancy, it could be heterotopic, so make sure you thoroughly assess the adnexas. And if we thoroughly assess our patients, we can aid in the diagnosis of non-tubal ectopic pregnancies, provide the best patient care with the best treatment, and ensure good patient outcome. Thank you.
Hi, everyone. Thank you very much for coming to our presentation tonight. My name is Ella, and this is Emily and Andrea. I think that a lot of you sitting here with us tonight would agree with me that discrepancies do exist in ultrasound measurements and reporting. These discrepancies may lead to over or underdiagnosing patients, which may lead to an increase in healthcare expenses. So tonight in our presentation, we would like to focus on 3 types of discrepancies: inter-observer, sonographer to radiologist, and inter-institutional, as defined on the screen here. We have conducted a literature review which we summarize current findings on these discrepancies with the aim to raise awareness and to explore its implications. So now Emily is going to start by talking about inter-observer variability.
Ultrasound can be subjective. How sonographic images are created and interpreted depend upon the unique combinations of each sonographer's education, experience, and idiosyncratic ways of scanning. This inherent variability in sonography can be difficult to eliminate. What can be more easily controlled is the way that sonographers both document and report their findings. Follow-up scans are often performed by different sonographers. In many instances, these scans require taking measurements of certain structures. This can introduce inter-observer variability as different sonographers may take measurements differently. A common follow-up scan is for AAA. For the sonographers in the room, how would you measure the AP dimension of a AAA? Would you measure it in the longitudinal or the transverse plane? Jacola and colleagues claim that there is inter-observer variability in measuring the AP dimension of AAA and argue that there is no gold standard in taking this measurement. Thapar and colleagues have also found that some sonographers may measure AAA using the internal wall diameter or external wall diameter. There is greater inter-observer variability when sonographers use internal wall diameter, as thrombus may make it difficult to locate the true borders of the wall. Jacola and colleagues claim that how sonographers measure the AP dimension of AAA can impact patient outcome, such as if they are operated on or not. It is therefore essential for different sonographers to take measurements consistently. Implementing standardized protocols may help to ensure and to help reduce inter-observer variability in measuring. Sonographers also write preliminary reports. Without standardized reporting, sonographers have numerous ways to describe their findings. Gamay and colleagues analyzed reports of thyroid sonograms. The sonographers did not use a standardized reporting system in the study. The authors found that over 97% of reports commented on nodular size, while less than 30% mentioned 2 or more criteria beyond size. This finding is concerning because it seems that without standardized reporting, there is significant inter-observer variability. Other studies which do implement a standardized reporting system, such as TIRADS, have found more consistency in reporting. A standardized reporting system may help to encourage sonographers to write more consistent and detailed reports, which can help to ensure no key findings are missed and help to reduce inter-observer reporting variability.
Now I'm going to switch the discussion to talk about sonographer to radiologist discordance. In BC, it is common practice for the sonographers to scan the patient, write up a preliminary worksheet, followed by the radiologist reviewing the images and write up the final report. We have therefore reviewed 3 studies where the authors compared the sonographer's interpretation of the scan to the radiologist. We have found an overall high agreement between the sonographer to the and the radiologist at 85 to 95%. Only 1 to 5% of the scans were found to have clinical impactful discrepancies. Interestingly, when disagreements do arise, different studies have contradictory results regarding each party's respective accuracy. As we can see on the screen here, Tesser's team found that when there's discrepant findings, the radiologists were correct 100% of the time. Versus Dawkins' team found that the radiologist was only correct half of the time. It's worth noting here that the 2 teams were using 2 different methods trying to determine the correctness of the scan. So basically, Tesser's team relied on follow-up data, such as data from lab tests, other clinical data, or data from other imaging modalities to determine the correctness. Versus Dawkins' team have a team of experienced sonographers and radiologists to review the images, and then where a majority vote determine the truth. So since Dawkins' team found that the sonographers and the radiologists have similar accuracy rates, let's take a look at who is better at identifying what pathologies. So as we can see on the screen here, the sonographers and the radiologists have the same accuracy rate when trying to determine gallbladder stones, gallbladder polyps, as well as gallbladder thickness. The radiologists, however, were better at picking up more subtle pathologies such as intrahepatic biliary dilation, pericholecystic fluid, and gallbladder sludge, versus the sonographers were better at measuring the common bile duct and determining the presence of a gallbladder.
Next, we'll be quickly taking a look at interinstitutional variability. Interinstitutional variability is largely affected by both the radiologists and sonographers at each site. Since my partners here have already talked about both these two categories, we will be focusing on the presence of a radiologist as the variable among sites and its impact on the final report. Different provinces in Canada each have different laws about whether or not a radiologist needs to be present during the time of an ultrasound examination. In Ontario, a radiologist does not need to be present during the time of imaging. This can be the case in some community clinics. A study done by Chung and colleagues argued radiologist absence is detrimental to accurate patient diagnosis. They studied 122 charts of patients who had an initial ultrasound done in a community clinic where a radiologist was not present and compared the results to subsequent imaging done in hospital by either CT or ultrasound where a radiologist was present. The authors found a disconcordance rate of 52.2% between the results of the community ultrasound and hospital ultrasound, and a disconcordance rate of 43.3% between the community ultrasound and hospital CT. Chung and colleagues argue that it is imperative to have a radiologist on site as they can rescan any areas they may be unsure of, leading to a more accurate patient diagnosis that ends up on the final report. In contrast, a study done by Systrom and colleagues found that it was radiologist experience rather than radiologist presence that had the most impact on the final report. They looked at 5.9 million charts to study which factors had the largest effect on the frequency for recommendations of additional imaging that were ending up on the final report. As we know, a radiologist may include a recommendation for additional imaging on the final report if the first exam for the patient yielded ambiguous results. Systrom and colleagues noted a correlation between an increase in radiologist experience and a decrease in the frequency for recommendations of additional imaging. This decrease in frequency may be attributed to the fact that a radiologist is gaining more confidence in their initial reports as they gain more experience. Since this study used a much larger sample volume and looked at a number of different factors that affect the final report, it can be argued that the final report is more affected by the individual radiologist who dictates it rather than the presence of a radiologist on site.
Through our research, we found that inter-observer variability can be reduced through the use of standardized protocols and reporting systems. However, we also noted that some studies claim there are high accuracy rates in the reports written by sonographers. Additionally, we noted that radiologist experience may have a larger impact on the final report rather than the radiologist's presence at clinical sites.
Through our literature review, we found that limited studies connect the variability in ultrasound to its impact on patient diagnosis. We recommend future research on making this connection. Additionally, to make sonographic results more reproducible and comparable among sites, sonographers, and radiologists, we suggest more standardization of protocols. We also recommend annual audits for quality control purposes and the continuation of rounds between sonographers and radiologists to encourage collaboration and learning. This concludes our presentation. Thank you very much for listening. We are open to any questions.
Good evening, BCIT faculty, family and friends, and fellow sonographers. My name is Haley. This is Sarah and Jana. We've compiled a literature review on carotid atherosclerosis, specifically soft plaque versus luminal stenosis. We hope to inform and encourage you all to routinely assess and document soft plaque when clinically indicated during carotid studies. According to the Mayo Clinic, a stroke occurs when blood supply to part of your brain is interrupted or reduced, depriving brain tissue of oxygen and nutrients. Luminal stenosis is the accumulation of plaque in the vessels feeding the brain, resulting in decreased perfusion. This is one of the causes of ischemic strokes. Plaque embolism occurs when a piece breaks off and travels to the brain, blocking blood flow in a particular area. Now, before we dive into these two topics specifically, let's look a little closer at the pathophysiology of plaque development. Atherogenesis is a gradual process beginning with endothelial damage. Risk factors include age, smoking, hypertension, diabetes, obesity, and atrial fibrillation. As the artery's lining is damaged, it becomes increasingly susceptible to monocyte infiltration. Monocytes infiltrate the tunica intima, initiating a cascade of inflammatory processes. As the plaque grows, smooth muscle cells travel into the tunica intima, creating a fibrous cap. Next, lipids from the bloodstream accumulate. Macrophages phagocytose low-density lipoproteins, together creating lipid-laden foam cells. Eventually, the consequence is an atheroma. Note the lipid-rich core. So now that we know a little bit more about how plaque develops, let's take a look at luminal stenosis. According to Spencer's curve, which describes the relationship between flow volume and stenosis, flow rate is theoretically maintained with up to 50% diameter reduction. Now, clinically, hemodynamically significant stenosis begins at 70% diameter reduction. And based on commonly accepted sonographic findings, peak systolic velocity measuring greater than 230 centimeters per second using spectral Doppler analysis indicates significant stenosis. However, as we know, many of our patients present with symptoms before plaque volume reaches this point. Although it provides valuable information regarding critical stenoses, peak systolic velocity is only one of many factors to consider when assessing carotids, as cerebrovascular events may occur in the absence of carotid stenosis. Another factor to consider is the circle of Willis. In the event of significant carotid stenosis, the circle of Willis is able to provide collateral blood supply to the brain. Now, on the other hand, 20 to 30% of ischemic strokes are triggered by the rupture and embolism of plaque. Vulnerable plaques can be identified by certain characteristics: a thin fibrous cap, a large lipid core, irregular surface or ulcerations, or intraplaque hemorrhage. Next, Sarah will be telling us all a little bit more about how we can identify these characteristics using ultrasound.
Thanks, Haley. So I'll also be asking a couple questions to see what is currently done in clinical sites. So intimal thickness is the measurement of the innermost layer of the blood vessel where atherosclerosis occurs. So a show of hands, how many people regularly measure the intimal thickness? Oh, okay. More than I expected. So we know that the normal thickness is less than 0.9 millimeters. But did you guys know that diffuse intimal thickness is actually part of an aging process? So thickening isn't necessarily pathologic, but it can predict plaque formation. So here's an equation which is graphed on the right. Sorry, I get my left and right mixed up from sonography, which shows the increase of, as we age, the intimal thickness also increases. It predicts not only cerebral vascular events, but also cardiovascular events. So we know that B-mode ultrasound is non-invasive and safe. So here's some blood vessels. So you want to measure the yellow line to the pink line. So when you're documenting, you want to measure 3 times to eliminate some error. You want your vessel to be horizontal for the best resolution. You also want to measure about at least 5 millimeters away from the bulb of the vessel, more proximal, and you do not want to measure the plaque. So here's an example of an abnormal one. It's about 1.2 millimeters here. Plaque echogenicity. So there's 5 different types of plaque echogenicities, from echolucent to calcific. So it's very subjective between sonographers and lots of error because, like, how do you determine if something's more black than the other or which is more white? So when you document, you want to document vulnerable plaque, which is more echolucent plaque, heterogeneous plaque, and also like multiple areas of plaque as well. And here's an example of an echolucent plaque. and then a heterogeneous, which has different echogenicities. So a show of hands, and in addition to documenting where is plaque, how many of you guys document like what sort of echogenicity you see? Oh, great, that's good. Okay. Oops. Oh, that's weird. Okay, something weird happened. So with plaque surface, you want to describe if it's smooth, irregular, or ulcerative. So ulcerative plaque is the most vulnerable plaque. It's actually 7 times more likely to rupture, but it's very difficult to identify on ultrasound. How many people have identified ulcerative plaque? Oh, okay. 2 people. So when you're documenting, you want to look for low echogenicity within the plaque. You also can sometimes use color Doppler to see flow reversal. And then if you want to rule out if it's just noise, then you can add pulse wave also. And here's an example of an ulcerative plaque. So here's a little summary of what I was just talking about with stable and unstable plaque. And here's an example of a carotid Doppler report. So on top of documenting the Doppler velocities, you could add your intimal thickness here, and also what sort of findings you find on your ulcerative plaque, or sorry, on your what sort of plaques you find. Now Jana will talk about her innovative ways of detecting plaque.
Awesome. Thanks, Sarah. Oh, okay, one sec here. So we had a little glitch with our slides, it looks like here. But so I'd like to talk to you a little bit about the future developments that have been happening in carotid ultrasound. So there's been some kind of exciting new things that have been happening. Just want to start with a show of hands. How many out there have performed or seen a contrast-enhanced echo study? Okay, a lot. Actually, that's really awesome. Same thing. Is that we're basically using this for carotid arteries instead. So how this works is basically an injection goes into a peripheral vein of a contrast agent, and that is full of microbubbles that are a very strong reflector for the ultrasound beam, basically using physics magic called harmonics. And the reason why this is important, it doesn't just illuminate the vessel, it also detects neovascularization. And the reason why we care about these tiny little vessels within the plaque is because they're actually a delivery system for the inflammatory process that actually progresses the atherosclerotic disease. They're also very weak and prone to rupture, and they would make these particular plaques very susceptible to an embolic event. So. There are some contraindications for using a contrast agent, though, such as a left to right cardiac shunt, if the patient has hypertension or a known allergy to the agent. So just to give you an idea of what it will look like on ultrasound, on image A here, we have a typical B-mode imaging of a soft plaque. On image B here, you'll see these tiny little microvessels as shown in these little arrows. And those little vessels would be something we'd really want to pay attention to because this particular plaque would be quite vulnerable to rupture. So next I'd like to talk about superb microvascular imaging. It's very similar to contrast-enhanced ultrasound as it also detects neovascularization. The bonus is it does this without an injection of contrast. It uses very advanced technology to suppress noise from the motion artifacts without losing the signal from these very small vessels. The one thing I found, though, there was a lot of limited research. They're using it a lot for different things like testicular ultrasound, but for carotid ultrasound, it's still fairly new. The next one I'd like to talk about is 3D ultrasound. So just a show of hands here, how many people out there in clinical have seen 3D ultrasound, probably at Women's or at VGH? I know they do that with a lot of scans. Okay, so actually that's pretty cool. That means 3D ultrasound is actually a lot more prominent out there in the clinical force. So this is essentially the same thing except for carotid arteries. And the reason why we care about this is because it actually determines the full volume of plaque. And the reason why this is really important is because plaque actually grows irregularly down the vessel walls. It grows 2.4 times faster down the length of the vessel than it does the circumference. So it's actually more accurate than B-mode image measurements, but it's still very important, so still measure. It's very, very important, but it is more accurate because there's less interoperatable dependency. And it's also very good for tracking treatments. So physicians found that with 3D ultrasound, when they were tracking the regression of a disease, that it was a lot more accurate for them to see how much regression had happened than just a B-mode measurement. The pitfall is, though, nothing's perfect. So with when the imaging is actually rendering, with there's vessels that have very minimal end diastolic flow, such as like the ECA, you're going to show up like almost like an occluded vessel. So that would be something you'd have to look out for. And lastly, this is kind of my favorite one, but I'll get to that in a minute, is shear wave elastography. This one's really cool because it actually determines the stiffness of the plaque within, and that in turn kind of tells us what the plaque is made out of, and that tells us the vulnerability. So basically, it's more physics magic. Shear waves are sent in with acoustic radiation force, and those waves that come back are measured using Young's modulus. Now, what is Young's modulus? That sounds like a weird cheese. But actually, it's actually a numerical constant used in physics that it's basically the slope of a line between stress and strain. So if you were to push on something, how much would it compress or push back? And they found this was very good and reproducible with little interoperator dependency. So that's really important because when you're doing a scan from a patient to the next, you really want to make sure, if you're keeping track of the disease, that it's very consistent. The pitfall, though, it is subject to flow velocity artifacts, just like 3D ultrasound. Now, because I'm a nerd, I'm a little bit of a sci-fi nerd, I want to get a show of hands here. Who has seen the movie Predator? Oh, you guys are awesome. Okay, so does anyone remember what Predator's vision looks like? Okay, are you thinking? I see you're all thinking. Right? I'm such a nerd. When I saw this one, I was like, yeah. Anyway, okay, so back to business. So what are we doing all this for? So that's great. We know what plaque looks like. We know why it's dangerous. Like, why do we care? Obviously, there needs to be a reason. So there are some treatments out there. For patients that have a stenosis that actually is over 70%, there are two options available. They can either get a carotid artery endorectomy, that's a really hard one to say, and a carotid artery stent. If the patient does have soft plaque, but not yet a stenosis, it's still something we'd want to consider having a chance to regress. There are two options available. They can reduce the lipids in the patient, and that can either be done by diet or through medications. So this kind of just brings us to our future recommendations. Okay, well, slide glitch, but anyway. So we would like to see proper education and training in the workforce just to show people the importance of documenting the soft plaque. And we'd also like to see people document the characteristics. So not just documenting the plaque, but if it's ulcerative, if it's inhomogeneous, those kind of things are actually really important to the patient outcome. We'd also like to maybe implement screening to possibly prevent stroke. So maybe when people are in certain demographics, I know that doesn't always work though when there's like already a backflow of people that are waiting for ultrasounds, but it's something that would be maybe good to have. And what we'd really like to see is maybe some more research done in some of the new developments, because some of it is really cool and it's very interesting, but there is a little bit more research that's needed. So I hope you guys learned a little bit about soft plaque and how important it is to document out in the workforce. Excellent.
Good evening, everyone. So we're going to be talking about emerging applications of 3D ultrasound and general sonography. I'm Jazreen, this is Stacy, and this is Doreen. So we will be talking about the benefits of 3D ultrasound, the physics behind a 3D probe, applications of 3D ultrasound, limitations, and any further recommendations that we have for future use. So a wise man once said, it's not a complete study unless you have used two different probes. So why not use a 3D probe? Additional relevant clinical information is found. It's a useful tool for achieving accurate diagnosis, and it provides lateral depth and slice thickness dimensions. So for the physics of a 3D ultrasound. Now, conventional 2D transducers are normally composed of a single row of lead zirconate titanate crystals, or also known as PZT, which send and collect ultrasound in the lateral direction. And originally, 3D transducers would require an electromagnetic transducer tracking system to be attached to them, and definitely relied on the freehand scanning, and therefore was very operator dependent. Now 3D transducers have multiple rows of PZT elements and are known as a 2D array transducer, of which elements can actually send and collect information in both lateral and slice thickness directions. And this provides full electronic control without the need for any tracking mechanisms. The 2D array transducer also eliminates some limitations of operator dependency and most motion artifacts while maintaining a frame rate high enough to provide close to real-time imaging. There are three main steps: volume acquisition, volume display, and analysis. Volume acquisition requirements include 7.5 to 15 seconds, an angle of 30 to 40 degrees, and a height and width as small as possible. Also, no other structures should be obstructing the area of interest. Now, common methods of volume display are surface rendering and multiplanar reconstruction, which we will go over next. And the acquired data will then be analyzed to aid in clinical diagnosis. So, like we just mentioned, there are two particular imaging controls, which when combined will allow for optimal imaging. These are known as surface rendering and multiplanar reconstruction. Surface rendering actually allows for depth to the acquired image. It allows for that three-dimensional effect and allows for an increased differentiation of texture and shape. Multiplanar reconstruction is what allows for the image to be constructed and visualized from three orthogonal planes, sagittal, coronal, and transverse, also known as X, Y, and Z planes. These planes can then be manipulated and rotated to translate information about these normal views. Another advantage is with 3D imaging, we can do post-processing and repeated translation and rotation of each section, and this makes it easier for physicians to collaborate and diagnose for future.
From Andreotti and Flischer's article, we found that 3D ultrasound has many applications in gynecological studies, such as contraceptive device localization, visualizing uterine anomalies, and differentiating pathologies. Here are some picture examples of different applications. This is a 2D versus 3D image of the same IUD. The 3D image shows the arm of the IUD embedded into the endometrium. Because 3D ultrasound can image in coronal, the interstitial area is well visualized. Here you can see the coils are in an accurate location for effective birth control. A and B are seemingly normal uterus. However, on 3D ultrasound, you can see that it's actually a unicornuate. This is a 2D versus 3D image of a synechia, and the 3D image depicts the synechia much clearer, while the 2D image shows it less clear. Here on the left shows an image of a uterus with a fibroid displacing the endometrium. On the 3D ultrasound, it reveals it's a submucosal fibroid. Lastly, 3D can be used to differentiate adnexal pathologies such as cysts, mass, and hydrosalpinx. This is especially useful to differentiate cysts and hydrosalpinx as it is difficult to appreciate the tubular shape in 2D. 3D ultrasound can be used to facilitate breast biopsy. Fenster et al.'s study used a mount, shown on the screen, with 3D ultrasound to collect samples which showed to be 95% accurate in sampling a 3.5 millimeter lesion. And this is the close-up of the mount. This can aid in doctors with difficult biopsies involving small lesions, superficial lesions, and mobile lesions. The breast biopsy involves a few steps. First, the breast tissue is stabilized by the compression plates, and the volume of interest is image seen on picture A. The software allows user to click on the target lesion, and the motor will move the transducer and the needle directly onto the lesion. The needle is manually inserted by the biopsy gun with real-time 3D imaging of the needle pass, seen on image B. Lastly, as shown on image C, another image is captured to confirm the pass went through the center of the lesion before the needle is removed. Another application of 3D ultrasound is prostate biopsy. Bax et al.'s article used this contraption for their 3D biopsy research. They used a software which takes the number and the area of needle passes so that urgent, repeated biopsy procedures are done accurately. The software generates an interface consisting of 4 panels shown on the screen A, B, C, D during the prostate biopsy. Picture A shows a real-time 3D transrectal ultrasound image that has been dynamically sliced to correspond with image B. Picture B is the real-time 2D image. Picture C is the 3D rendered model of the prostate with corresponding scan plane location. And picture D shows the 3D model with biopsy targets. A target ring is displayed to show all the possible needle paths to allow the doctor to plan the shortest trajectory path by rotating the probe.
Okay, so we've been talking about 3D, but I'm going to add another dimension and talk about 4D for a sec. So 4D is simply just a moving clip of a 3D acquisition, as we all know. As you can guess, this would be very useful for fetal hearts, which are often quite difficult to chase around. It's hard enough to get diagnostic images, but truly assessing a fetal heart can be quite challenging. So 4D ultrasound not only helps remove the inter-operator variability from scan to scan, but acquisition can be done in both grayscale and color, and linear and volume measurements are both possible. So instead of trying to assess this moving target and obtain diagnostic images in just 2D, a single 4D clip can provide all of the diagnostic information that we would typically need for a fetal assessment. One study reported that 4-chamber views were obtainable in 70% of cases, and outflow views were obtainable 83% of the time. Non-diagnostic data sets were attributed to the same limitations that we typically face, which is just increased maternal body habitus, anterior placenta, and poor fetal position. Not only can 4D be used to assess normal hearts, but congenital heart disease can be diagnosed as well. One study we saw reported that 4D ultrasound accurately diagnosed congenital heart disease in 94% of cases, and another reported accurate diagnosis in 91% of cases. And that's all from one 4D acquisition, which is very cool. Similarly, 3D ultrasound is very useful for fetal brain anomalies. The brain is a very complex structure, so being able to manipulate a 3D volume with rotation and translation can be extremely helpful to figure out what's going on. The studies we looked at showed that 3D is very helpful to diagnose hydranencephaly, holoprosencephaly, and hydrocephalus. This is an example of semilobar holoprosencephaly, for which other features can also be distinguished with 3D, such as facial anomalies that often present in cases like these. Abdominal aortic aneurysms are often diagnosed with ultrasound and are frequently assessed with ultrasound to monitor their progression. Depending on the size of the aneurysm, these patients can be scanned relatively frequently. Real-time dual-plane imaging of aneurysmal sacs is particularly useful to ensure accurate and reproducible measurements are taken over serial scans. Dual-plane imaging allows for simultaneous visualization in orthogonal planes. Lowe et al. Reported that using dual-plane for measurement of aneurysmal sacs yields reproducible equivalent measurements to CT angiography and is actually more accurate than our own 2D measurements. AP diameter of the aneurysmal sac is the parameter that is typically used for predicting the risk of dissection and rupture. However, the AP diameter is not the sole factor in determining risk of rupture. Sac morphology, volume, and thrombus load are all important factors in determining the timing of intervention, and these factors are routinely assessed with CT angiography. You can see on the left a 3D CT reconstruction of an aneurysmal sac, and on the right a 3D ultrasound. 3D ultrasound could provide a non-invasive, non-irradiating, and inexpensive means of risk stratification, as it can yield the same amount of information as a CT, but in real time. So now that we've hopefully convinced you to start using 3D, I guess we should talk about limitations. Of course, extra time is required for acquiring these volumes. More staff training will be required, and equipment and software can be a bit pricey. Additionally, really large structures are difficult to assess because they just physically don't fit within the field of view. Before 3D ultrasound becomes commonplace in our departments, further prospective studies assessing the accuracy and reproducibility of 3D, as well as comparing 2D and other modalities to 3D ultrasound, is needed. To sum up, 3D ultrasound provides additional information and for assessment and diagnosis. We do want to reiterate that it's, of course, never going to replace 2D, but it can be a really helpful complement to help solve the clinical question. Thanks.
Hi, good evening, everyone. Today we're going to talk about emerging technology for cancer detection in dense breast tissue. My name is Helena, this is Stephanie, and Sherry. Today we're going to discuss breast cancer risk factors, current screening tools and detection rates, prevalence of dense breast tissue, implication on detection, and we're going to introduce automated whole breast ultrasound system called ABIS, and we're going to compare ABIS versus mammography in the setting of dense breast tissue. And lastly, gaps in literature and suggested future studies. According to BC Cancer Agency, about 1 in 8 women will develop breast cancer in her lifetime. Regular screening mammography is recommended for all asymptomatic women who is 40 years and over in BC, with a follow-up mammography every 2 years. If the woman falls into higher risk categories, such as family history of breast cancer, then a mammogram is recommended every year. Mammogram uses a much lower dose of X-ray than a typical chest X-ray, and it is well known for its early detection of breast cancer. It has been the standard imaging technique for breast cancer screening and has successfully reduced breast cancer mortality. Overall, the sensitivity of mammography for the detection of breast cancer in normal to fatty breast tissue is about 85%. Unfortunately, when it comes to dense breast tissue, it has a low sensitivity value of 30 to 48%. The machine is designed to flatten the breast tissue and acquires images in two planes called craniocaudal view and medial lateral oblique view. Within the two planes, mammogram produces summation images where the breast tissue overlaps in each view. Breast cancer lesions can easily hide behind the overlapping dense tissue, so it is hard for the reader to pinpoint the exact location of the lesion. As you can see, breast tissue is mostly made of fatty tissue, ducts, and fibrous granular tissue. However, it is possible for the cancer lesions to live in a deep posterior area called retromammary layer, and it is difficult for a mammogram to image this area due to the inability to flatten to the necessary degree. A mammogram can easily miss cancer lesions living in the retromammary layer. As you can see here, dense breast tissue shows up on the mammogram as white or echogenic, which unfortunately has a very similar echogenicity to the breast cancer lesions. Like you can see on the left image here, small cancer is easily seen on fatty breast tissue. However, imaging on the right side demonstrates a larger cancer lesion, which is difficult to see on dense breast tissue. So, what is dense breast tissue? Stephanie?
Thanks, Helena. So we've just heard how dense breasts can be very problematic when it comes to cancer screening using mammography. But you might be wondering, what is dense breast tissue? Dense breast tissue is an inherent difference in the overall composition of the breast compared to normal fatty parenchyma. Dense breasts have increased levels of fibrous or glandular tissue and less fatty tissue overall. According to the Breast Imaging Reporting and Data System, or BI-RADS criteria, established by the American College of Radiography, there are 4 different levels of density classification. Level A is composed almost entirely of fatty tissue. Level B is composed mainly of fatty tissue with some scattered areas of density throughout. Level C is heterogeneous, with a fairly mixed echotexture. Level D, extremely dense. These breasts are composed almost entirely of this fibrous or glandular tissue. For the purposes of this presentation, we will be focusing on levels C and D when we're referring to dense breasts, so please keep these 2 images in mind. So how common is this? Current research states that dense breast tissue is present in over 40% of all women. And so, when assessing a woman's likelihood of developing breast cancer, physicians must take into account the patient's overall set of risk factors. Among these, one of the greatest significant factors contributing to a woman's likelihood of developing cancer is the presence of this dense breast tissue. The clinical implications of this are staggering. Women with dense breasts are twice as likely to develop breast cancer. Unfortunately, due to the limitations of mammography screening practices used today, these cancers are also more likely to be missed. As we have already mentioned, ultrasound is not currently used as a screening tool in BC. Instead, it is used for diagnostic evaluation purposes only. Researchers from the University of California wanted to challenge these screening norms by conducting a comparative study evaluating breast cancer detection rates of mammography versus ultrasound. Their results show that ultrasound had a significantly higher sensitivity rate compared with mammography, not only in the setting of fatty tissues, but also in dense breasts. They hypothesized that if ultrasound were used in conjunction with mammography, that sensitivity rates could approach the 95th percentile range, which they say could be comparable to the sensitivity of MRI, but at a fraction of the cost. Researchers from the University of Pittsburgh Medical Center came to similar findings in their research. Their studies emphasized not only the improved sensitivity rate of ultrasound, but also suggest it as a more cost-effective screening tool in resource-poor countries. What's more, ultrasound has the benefit of zero radiation exposure, deeming it much safer than mammography. It is generally well tolerated by patients and does not require any painful compressions. Overall, researchers found that the implementation of ultrasound as a screening tool could mean for better and earlier detection of breast cancer at a reduced cost to the medical system as a whole. Ultrasound also fares better than mammography in its ability to image right to the posterior chest wall. And as you can see from the far right image, ultrasound's differentiation of a cancerous lesion is far more perceptible compared with mammography. And now Sherry is going to talk to us about some new and exciting technology for breast cancer detection.
Okay, thank you, Steph. So, after hearing all these great benefits of ultrasound, you may ask, why isn't it widely used as a screening tool? Well, long story short, it would just take too long for techs to scan 2 breasts every single day, and imagine all the breast cases that you would get doing that every day. Well, that time that you spend scanning breasts can actually lead to more injuries for the sonographers. And one of the biggest reasons is the operator dependency of this modality. Different sonographers will obtain different images, and that lack of consistency makes it very challenging for the doctors to follow up with that patient. So now we're here to talk about this new technology in breast imaging. It's the automated whole breast ultrasound system. It's been around for the last 5 to 10 years, and we're really excited to tell you more about it. So the ABUS beam forming technology creates a focal zone at every depth. So as you're scanning, it creates a focused pixel at every depth. So the ABUS acquires millions of focused pixels, and it scans the breast at very high frame rates. So the image resolution you would get is incredible compared to mammography, where you're using the summation technique to condense a 3D structure into a single 2D image. And it's also a lot better than the traditional ultrasound, where you maybe acquire 20 to 30 images throughout one exam at maybe 1 to 2 focal zones, depending on how the sonographer has their settings. And even if you were to take a cine sweep, you would maybe get about 100 to 300 images per sweep. So with ABUS, the radiologist will have more relational and spatial information. So in the reading room, the doctor can have the mammo on one side and then the ABUS images on the other. And if they see an area of concern or if they're suspicious over one area, they can place a point on that area, and the doctor will immediately have information such as where it is on the breast, how deep it is in the tissue, and how far it is from the nipple. So this increases specificity of the exam, and it will reduce the amount of unnecessary callbacks for the patient. So with ABUS, many of the contraindications of traditional handheld ultrasound is eliminated. The operator dependency aspect of the exam is taken away, as the machine will do a lot of the scan, and the exam is easy to set up, and it's done in a very quick amount of time. For a Philips ABUS system, the Sonocini, they claim they can do a full volume bilateral breast ultrasound, including the axilla, within about 30 minutes. And with GE, their Invinia ABUS system uses their special reverse curvature probe, and it's able to complete a full 3D breast volume scan with a single pass over the breast tissue. And they say that they can have the patient in and out of the room within about 6 minutes. So from our research, we see that by adding ABUS to mammo, it improved the breast cancer detection from 23 to 46 out of the 57 types of cancers in that study. And with addition of ABUS,
we see that the sensitivity improved from 40% from mammography only to 81%. And you can see in the middle column on the side there that ABUS alone has a superior sensitivity compared to mammo. So currently in Vancouver, from our knowledge, there's only one ABUS machine, and it's located at Mount St. Joseph's Hospital. It's currently not routinely utilized. So we are wondering, is it because the radiologists aren't currently interested in reading these extra images? Is it because they can't figure out who will perform these exams? Will it fall under the responsibility of a mammo tech, or will it be done by the ultrasound techs? How will the billing work? So currently in Canada, there's not enough long-term data on the demand for ABUS. Since it is a relatively new technology, we hope that there will be more research coming out in the next few years because we believe that ABUS is a really great technology, and we hope to see it improving breast cancer detection in dense breast tissues. Thanks for listening.
Good evening, ladies and gentlemen, and thank you for staying. We really appreciate that. Tonight we, Simon, Christina, and myself, Tamara, are presenting on early targeting of disease using strain. So our topics tonight are current LV assessment and limitations, what is strain, an introduction, the method, application, bullseye patterns, and limitations. So current LV assessments include visualization of wall thickening and wall motion symmetry, and those would be subjective measures. Then the quantitative measures are ejection fraction, Simpson's biplane, tissue Doppler, and 3D volume. There are some limitations with regards to these, and as some of our previous presenters have pointed out, there's expertise in experience variation, image quality, lack of standardization, and lack of regional wall motion information, one-dimensional measurements, and mechanical quality variability. So before we continue, imagine if you can that this is our wonderful heart. And I'm going to just demonstrate the three main dimensions that the walls of the heart move. We have longitudinal, so up and down, okay, the lengthening and shortening of the muscle. We have radial, in and out, lengthening and shortening of the muscles. And we have circumferential, so twisting, counterclockwise and clockwise of the heart muscles. Now, the reason I'm showing you this is because the definition of strain can be a little confusing. The definition of strain is the evaluation of shortening, lengthening, thickening of myocardium in these three dimensions that I just demonstrated. So the software that is used in our echocardiography takes advantage of the longitudinal measurements. So if you imagine this is the heart again and we're moving up and down, what happens is it takes a cross-sectional area of the heart and divides these segments into 16 to 18 segments, and it uses speckle tracking to track the start of the movement to the end of the movement, and then it plots these on graphs. And these graphs can be used as a plotted graph or a bullseye graph. So that is what strain is and how it works. And I'm going to pass this over to Simon, and we are going to talk about the method.
Thank you, Tamara. Okay, I'm going to briefly explain how to measure strain in clinical setting and its applications and limitations. To calculate strain, apical 4 to 3 chamber moving clips are obtained. Those clips are optimized for left ventricle. Then endocardium is traced in mid-systole, and strain software would generate 3 lines, as you see here, that outline endo, myo, and epicardium layers of the heart wall. Next, the strain is measured for each wall, and an average value is generated that is called global strain value. A strain software would also produce a bullseye map that I'm going to explain later how it looks. Some strain, application of strain. A strain is beneficial in emergency situations. For example, a strain is done on a patient who had acute myocardial infarct and where the physician wanted a quick assessment of the myocardium health and there is no enough time to do a full echo. Strain is also used in patients who are on chemotherapy or antiviral drugs. These drugs would have negative effect on the heart function in a long run. So strain would evaluate the health of myocardium before the patient would become symptomatic. And this also helps physicians to adjust medication as needed. I'm going to pass you next to Christina.
As Simon mentioned, strain can be represented graphically, but most commonly it is shown as a bullseye map. As you can see, the normal values will appear in dark red, and the abnormal values will appear in lighter color. The more abnormal the heart motion, the lighter the color, because the value becomes more positive, and as the heart is moving completely in opposite direction, the color will appear in blue. When trying to diagnose early stage of disease, strain has a definitely upper hand over 2D imaging. As you can see on the screen, the top image displays short axis of athlete's heart, and the bottom image is of a patient with mild ventricular hypertrophy. Both walls measure 12 millimeters, and images look nearly identical. It wasn't until strain was applied that the true difference has emerged. In case of an athlete, which is image A on the left-hand side, strain values remained normal. In case of a patient with LVH, it is easy to see abnormalities in the heart walls where the muscle was most affected. Difference is seen before it becomes apparent in 2D echo. Strain can also help differentiate different types of LVH, such as asymmetric HCM in the image A on the right-hand side versus apical HCM on image B on the right-hand side. And as Simon mentioned, this can help in managing patient outcome and in monitoring patient progress. Also, the strain can be used to help correctly diagnose disease. As you can see, the two images appear very similar on the 2D echo. It's hard to tell which one is amyloidosis and which one is concentric HCM, because other factors such as settings on a particular machine and how sonographer operates the machine can affect final acquired image. But when strain is applied, we can see the typical apical sparing pattern that is common in early stages of amyloidosis versus the more diverse patterns of HCM, which rarely involve apical sparing and most commonly involve asymmetric dysfunction as seen in the first image on the right-hand side. And it's your turn.
Okay, next I'm going to talk about some limitation. There are some limitations to strain. As we learned in echo, garbage in is equal garbage out. For example, we need the right angle to capture the 3 clips. Otherwise, the strain package would not be able to recognize all wall segments and measure them equally. Strain is also sensitive to external noise, but by increasing wall filter, we would reduce our spatial resolution of our images. Last limitation would be concerning heart position, body habitus, and heart rhythm. For example, strain would be hard to measure on patient with atrial fibrillation. Due to this limitation, of course, we would have a hard time measuring strain on every single patient who comes in. Next, I'm gonna pass you to Tamara.
So, in conclusion, while strain is a valuable qualitative diagnostic tool, it comprises only as part of a full echo workup. So, to definitely get an accurate diagnosis for the patient's disease, we recommend both the full echo and strain. Thank you. We'll take questions over here.
Hi, my name is Michaela.
And my name's Bree.
And today we're going to be talking to you about the importance of the three-vessel view in obstetrical ultrasound.
In our presentation today, we are going to talk about the following topics. What is the three-vessel view? What it looks like in a normal heart, how to recognize an abnormality in this view, and what the benefits are of implementing this view in obstetrical ultrasound. As sonographers, it is part of our role to assess the fetus during pregnancy to detect any abnormalities. During the second trimester detailed ultrasound, we use a number of different views to assess the fetal heart in order to screen for a congenital heart defect. A congenital heart defect is the most common type of birth defect. It occurs in up to 8 to 10 out of 1,000 infants that are born full term, and this number is up to 10 times higher in infants that are born preterm. Up to 50 to 60% of infants born with a congenital heart defect will eventually require some form of surgical correction after they are born. This is why it is extremely important to detect a congenital heart defect early, as it reduces rates of perinatal morbidity and mortality.
Currently, the standardized views set by Perinatal Services BC are as follows. The 4-chamber view, along with the left and right ventricular outflow tracts and/or the short axis view. Together, these views are good at detecting most congenital heart defects, but still a fair number are being missed prior to birth.
So what is the three-vessel view? The three-vessel view is a view across the fetal chest that assesses 3 great vessels: the pulmonary artery, the aorta, and the SVC in a cross-sectional view.
To obtain the 3-vessel view, you will start in a 4-chamber view. From there, you will slide superiorly on the fetal chest towards the fetal head, and once you sweep past both outflow tracts, you will arrive at the 3-vessel view.
This is what the three-vessel view looks like in a normal heart. We have anterior and posterior on the fetus, and fetal left and right. From right to left, you will see the SVC and the aorta appearing as 2 small circles, with the pulmonary artery appearing as a straight line. The pulmonary artery will be the largest and the most anterior out of the 3 vessels, followed by the aorta, with the SVC being the smallest and the most posterior out of the 3.
Now that we've covered the normal appearance of the 3-vessel view, we're going to be talking about the abnormal appearance of the 3-vessel view. We have put these into 3 different categories of characteristics we can classify these on: the number of vessels, vessel size, and the spatial relationships between the vessels.
First, we are going to talk about the number of vessels. Like the name suggests, there should be only 3 vessels seen in the 3-vessel view. However, with certain congenital heart defects, only 2 vessels may be seen, or an additional 4th vessel may be seen. When only 2 vessels are seen, this may be indicative of certain conditions such as truncus arteriosus, which is seen in this image here. In this condition, the aorta and pulmonary artery both branch off from a single common root. Therefore, in the plane that the 3-vessel view cuts through, there are only 2 vessels seen, the SVC and the common truncal vessel labeled TV in the image up here. Another condition, dextrotransposition of the great arteries, or DTGA, may also show only 2 vessels in this view. In this condition, the aorta and pulmonary artery switch places and are connected to the wrong ventricle. In addition to the switch, the pulmonary artery gets displaced a bit posterior relative to the aortic arch, therefore giving the appearance of only 2 vessels in this view.
Two other conditions, aortic atresia and pulmonary atresia, may also cause only two vessels to be seen in this view. This is because in severe cases of these conditions, the aorta and pulmonary artery may be too small to fully appreciate on 2D ultrasound, giving the appearance of two vessels. When four vessels are seen in this view, this may be indicative of a condition known as persistent left superior vena cava, which is shown in this image here. In this condition, there are two SVCs that develop, a normal right-sided one, labeled RSVC in this image, and an additional left-sided superior vena cava, which is labeled LSVC at the top of this image here.
Now we're going to discuss vessel size discrepancy in the three-vessel view. So as we previously talked about, the pulmonary artery should be the largest vessel of the three, followed by the aorta, and the SVC being the smallest. When you have a significantly larger aorta, this raises concern for a condition called tetralogy of Fallot. Tetralogy of Fallot is a combination of four different heart defects, a VSD, an overriding aorta, right ventricular hypertrophy, and an atretic pulmonic valve. And tetralogy of Fallot almost always has an abnormal appearing three-vessel view. As seen in the picture here, you can see the center vessel, which is the aorta, is significantly larger than the pulmonary artery, which is to its left. In 2016, a study performed almost 3,000 fetal echoes. And of those 3,000, 31 fetuses were found with an abnormal three-vessel view with a larger aorta than pulmonary artery diameter. And of those 31, 25 fetuses had tetralogy of Fallot or a tetralogy of Fallot variant. The remaining 6 had an abnormal aortic valve or a dilated aortic arch. So all 31 fetuses in this study that were found with an abnormal three-vessel view had some sort of congenital heart defect. Other conditions that have an abnormally large aorta in comparison to the pulmonary artery are pulmonary stenosis, pulmonary atresia, tricuspid atresia, which is imaged in the second image here, and Epstein's anomaly. When you have a significantly smaller aorta, this raises concern for coarctation of the aorta, interruption of the aortic arch, which is seen in these two images here, aortic atresia. And although rare, sometimes you can have an abnormally larger SVC, which raises concern for a condition called total anomalous pulmonary venous return. As we know, the four pulmonary veins should drain into the left atrium, but sometimes they can be misdirected into an abnormal atrium or vessel, and one of these vessels being the SVC, which creates enlargement.
And the last abnormality we will talk about is the spatial relationships between the vessel. Like we mentioned earlier, the three vessels in the three-vessel view are arranged in a descending line from anterior to posterior, with the pulmonary artery most anterior, followed by the aorta, with the SVC being the most posterior. When the aorta is seen to be anteriorly displaced, this may be suspicious for conditions such as DTGA or double outlet right ventricle, which is seen in this image here. In this image, the aorta, labeled A, is displaced anteriorly relative to the pulmonary artery and can be seen almost side by side with the pulmonary artery. A couple other conditions that may also cause an anteriorly displaced aorta is tetralogy of Fallot, a right-sided aortic arch, and a persistent left superior vena cava. And although rare, the aorta may be seen to be posteriorly displaced as well. This may be due to conditions that cause an obstruction on the left side of the heart, such as hypoplastic left heart syndrome, seen in this image here, and interruption of the aortic arch. In this image, the aorta is much smaller than the pulmonary artery and displaced a bit more posterior relative to its normal position.
So now that we've talked about the abnormal three-vessel view in a variety of conditions, we're going to talk about the benefits of implementing this view in the routine detailed ultrasound. So one of the biggest benefits is that it is relatively easy to obtain. As sonographers, we know that assessing the fetal heart can be quite challenging due to a variety of factors such as fetal movement and position and maternal body habitus. This view is also in the same plane as the four-chamber view, which is a mandatory view, and if the four-chamber view is obtainable, the three-vessel view should be as well. Another benefit of implementing the view is that it has relatively straightforward anatomy. We can directly compare and assess these vessels side by side, which make it easier to detect abnormalities.
Lastly, the most important benefit of using the three-vessel view is that it improves the chances we are able to detect a congenital heart disease. Again, many congenital heart diseases are extremely subtle and may appear normal in certain views. This is especially true if the exam is technically difficult with unclear heart views. An abnormality could easily be missed. This is why adding in the three-vessel view in addition to the standard view set by Perinatal Services BC can help improve the chances of detecting a congenital heart disease in utero, especially a disease that affects the great vessels.
So, in summary, the lifespan of a fetus can be highly dependent on early detection of congenital heart defects. Therefore, it is really important that we do everything we can to detect these defects in order to give the doctors, perinatologists, and families time to prepare to ensure best possible outcome for these fetuses.
Oops. As ideal as it would be to have every pregnant patient undergo a detailed fetal echocardiogram, this is simply not feasible due to resources and time. Therefore, the standard protocol for a detailed ultrasound should be as effective as possible. If the three-vessel view is purposefully and knowledgeably utilized, in addition to the standard view set by Perinatal Services BC, it can be a very valuable tool. One issue that all of us sonographers struggle with is time constraints. We are constantly expected to do more with less time. However, the three-vessel view is not a difficult or time-consuming view to obtain. We believe that the improved chances of detecting a congenital heart disease in utero is well worth the minimal extra time and effort that it takes to obtain it.
Thank you. That concludes our presentation.
Hi everyone, my name is Jackie Carson. This is Leanne Dickey and Valerie Cousset, and as Tammy said, today we're going to be discussing the ultrasound assessment of placenta accreta. So what is the placenta? The placenta is an organ that bridges the gap between maternal and fetal circulation. It's connected to the fetus by the umbilical cord. This enables the exchange of nutrients and gas, as well as the elimination of waste, and it also carries out various endocrine functions. It is composed of the chorion frondosum, which is formed from the fetal trophoblast, and the decidua basalis from maternal uterine tissues. Chorionic villi protruding from the chorion frondosum project into the decidual cells. So in this image, we're just showing kind of various images of the placenta. What is placenta accreta? The placenta accreta spectrum occurs when some or all of the placenta is attached abnormally to the uterine wall. A lack of normal decidua basalis, like I said, the maternal uterine tissue, leads to this abnormality. This can be broken down further into 3 categories, depending on the involvement with the myometrium. Here we can see placenta accreta vera, where the placenta attaches to the myometrium without invading the decidua. Next, placenta increta, when the placenta attaches into the myometrium. And finally, placenta percreta, where there is placental adherence through the myometrium serosa and into surrounding organs. So why is it important to diagnose? Abnormalities of the placenta are one of the highest known risk factors leading to stillbirth. And when placenta previa is diagnosed prenatally, a hysterectomy can be planned for the woman, and she can have this performed directly after her C-section at a tertiary care center. If it's not diagnosed prenatally, the maternal death could occur due to excessive bleeding. Some common risk factors include the lack of normal decidua basalis, often caused by past trauma to the uterus, leaving the myometrium scarred and more susceptible to invasion. This can be due to uterine surgery or C-section. Increased surgeries increase the degree of risk. Placenta accreta is on the rise due to the increasing incidence of cesarean sections performed over time. So in this first graph, you can see that for a woman who's had 1, 2, 3, or more C-sections, her risk of having placenta accreta increases substantially with each pregnancy. Moreover, more C-sections are being performed each year, so this risk continues to rise. As you can see, in 1982, approximately 12% of deliveries were were C-sections, whereas this number rose to almost 35% in 2011, and this number continues to rise. Women with a history of C-section in conjunction with low-lying or placenta previa are the highest risk group of developing placenta accreta. Other risk factors include advanced maternal age and prior history of placenta accreta.
So there are a few observations a sonographer can make at the time of the dating ultrasound. First, you can assess the location of the gestational sac. Low and anterior can indicate a higher risk. Also, look for myometrial thinning, as seen in this image. Abdominal free fluid is specifically correlated with placenta percreta. Unfortunately, there are many limitations in the first ultrasound, which can become a problem if they do a D&C and it's undetected and a large hemorrhage can occur. So this is the second trimester assessment protocol for BC Perinatal Services. As sonographers, we always thoroughly assess the placenta. This means looking at the number of placentas if there's more than one, their location, their relationship to the internal cervical os, and the placental cord insertion. By the time we're doing the detail ultrasound, there are many more clues for placenta accreta. First, we can look for abnormal placental legs. So you can notice if they're long and thin, indicating pathology, or if they're more round, which suggests that they're normal. We can also look for increased vascularity within the legs. So here you can see an abnormal placental leg, which is long and thin. This is a more vascular leg, which is also considered to be pathologic. And this is a round, normal leg. Another area of assessment should be the uterine bladder serosa. This normally appears as an echogenic line. However, in the case of placenta accreta, it can be lost or diminished. If you suspect placenta accreta, you can perform an EV using a partially full bladder. And sometimes you can see the vessels invading the bladder. However, you need to be careful because at the end of the second trimester, there may be normal bladder varices. We can also look at the retroplacental clear zone or clear space. This is the area between the placenta and the myometrium, which is considered to be the decidua basalis and is represented by this black arrow. When assessing the retroplacental clear zone, we're looking not only for its presence, but also whether or not it's thin. If the zone appears thin or absent, we should suspect accreta. This green circle shows a normal retroplacental clear space, and this red circle shows a diminished clear space. We should also assess these areas with CDI to look for more vascularity.
Assessing the placenta is part of every third trimester scan. Again, we note the number, location, and relationship to the internal os. This is especially important when the placenta has been known to be low-lying or previa. 3D assessment of the placenta is a budding area of research and its role has not yet been solidified. It provides more easily understandable information for medical professionals, patients, and their families for the purposes of decision making. 3D blood flow analysis can show the intricate vessels of the placenta. It shows their relative number, size, and route of flow. In one study, 3D power Doppler rendered a 97% sensitivity in the diagnosis of placenta accreta. Although 3D assessment may be useful in the future, more research as well as training and upgrading of equipment is necessary first. MRI can be a useful tool to aid in the assessment of placenta accreta. Focal bulging and heterogeneous texture of the placenta is highly indicative of placenta accreta. Here we see a heterogeneous uterus. Because MRI is superior to ultrasound in the assessment of how far the placenta extends outside the confines of the uterus to other organs within the pelvis, it can be a great aid in forming a patient management plan. Here we see the placenta invading the abdominal wall. If placenta accreta is suspected or known, a group of healthcare workers will work together to plan the patient's delivery well ahead of time. The surgical recommendation that carries the lowest morbidity rate is a hysterectomy via cesarean before 36 weeks gestational age. If the patient strongly desires another pregnancy, a more conservative approach may be used by having a C-section without a hysterectomy. In this situation, the placenta is left within the uterus. The patient must be counseled to understand that this option carries a much higher chance of maternal morbidity. When making these decisions, it is also very important to acknowledge the severity of placental adherence. The risk of life-threatening complications increases drastically the more deeply adherent the placenta is. If this higher risk option of leaving the uterus and placenta in after a C-section is chosen, the patient must be followed up with serial MRI and ultrasound assessments. In a blind study where radiologists and maternal fetal medicine physicians did not know anything about a patient and only reviewed images, sensitivity for diagnosing placenta accreta was only 53.5%. Overall, the main message that we would like you to take away from this presentation is that thorough history taking can make a huge difference in guiding your assessment. Recognizing the presence of placenta accreta is a challenging task. However, if you gather a good history and you know how many risk factors your patient has, you'll be better equipped to optimize your search. Thank you.
Hi everyone, my name is Erica, and along with Ashley and Hannah, this is our presentation on a sonographer's role in endometriosis identification. So we'll start off with what is endometriosis. Endometriosis is a medical condition that occurs when the lining of the uterus, called the endometrium, grows in other places, such as fallopian tubes, ovaries, or along the pelvis. When that lining breaks down, just like regular lining in the uterus, it produces menstruation and won't have anywhere to go. This disease affects up to 15% of reproductive age women and increases to 30 to 50% of women who additionally experience chronic pelvic pain and infertility. So signs and symptoms of endometriosis can be vague and mimic other chronic pain disorders. They include dyschezia, which is painful or difficult bowel movements, intermittent diarrhea and constipation, hematochezia, which is bloody bowel movements, secondary dysmenorrhea, chronic pelvic pain, dyspareunia, which is painful sexual intercourse, or dysuria, which is painful or difficult urination, irritable bladder, hematuria, fatigue, infertility, indigestion, and nausea. So the diagnosis of endometriosis is not clinically achieved through ultrasound. Women usually suffer for many years before a diagnosis is reached. It can take an estimated 8 to 12 years for a definitive diagnosis. The gold standard today for a definitive diagnosis of endometriosis is confirmed by laparoscopy. This is when a surgeon makes a small incision near the belly button and fills the abdomen with gas to get a better look at the internal organs. A laparoscope is inserted, which is a thin tube with a camera on it, to look for scarring and/or lesions on the uterus, ovaries, fallopian tubes, bladder, or other organs. Removal of endometriosis, scarring, and/or lesions during the laparoscopy can also be achieved through this method. Depending on how much endometriosis the surgeon must look for or remove, the procedure can last anywhere from 30 minutes to 6 hours.
Okay, so what do we see with ultrasound? Sonographers are trained to identify endometriosis through the finding of endometriomas and the sliding organ sign. Endometriomas are typically well-visualized cysts containing low-level echoes and described to have a ground glass appearance, as you can see in this image. The sliding organ sign is achieved when the sonographer applies pressure to the cervix using an endovaginal probe. The sonographer then watches to see if the uterus and cervix slide independently from other organs. The sliding organ sign is positive if the uterus and cervix slide freely. As you can see in this video clip of the anterior uterine wall sliding freely from the abdominal wall. The sliding sign is negative if the organs such as ovaries move as if attached to the uterus or cervix. A negative sliding sign can indicate endometriosis. Aside from these two potential findings, there's minimal assessment for endometriosis. Deep infiltrative endometriosis, also known as DIE, is a more serious form of endometriosis. It is often associated with infertility, along with symptoms that Erica discussed earlier. This form of endometriosis can be located in multiple locations. It's most commonly found in the uterosacral ligaments, the posterior vaginal fornix, the retrocervical region, rectovaginal septum, vesicouterine pouch, the bladder, and the anterior wall of the rectosigmoid. These locations are suboptimal when it comes to ultrasound assessment, and therefore lesions can be difficult to visualize with ultrasound. As pelvic pain is one of the main symptoms of endometriosis, an ultrasound is commonly recommended. While ultrasound can be effective in diagnosing individual lesions such as endometriomas, it is not very effective at identifying deep infiltrative endometriosis or diagnosing the extent of endometriosis. Research studies have shown, Research studies have shown that with specific training to assess for endometriosis using ultrasound, a sonographer can become more effective in the diagnosis process. One study had 94 patients who underwent laparoscopy for endometriosis. These patients all had endovaginal ultrasound prior to their surgery. The same sonographer scanned all 94 patients. The sonographer had previous gynecological ultrasound training but had not performed endometriosis dedicated scans. The sonographer completed training prior to assessing the patients specific to deep infiltrative endometriosis scanning. As you can see on the table, the sonographer was proficient in the diagnosis process. As expected, the sonographer was 100% accurate in identifying endometriomas. There were a range of different dye nodules that the sonographer was also able to successfully identify. The diagnosis of bladder nodules, 99%, was the most accurate, while the diagnosis of uterosacral ligament nodules was least accurate at 65%. With formal training focused on endometriosis detection, sonographers can become more efficient in the diagnosis process. In the mentioned studies, sonographers were given specific focused training to identify dye specifically. The sonographer would then perform an endovaginal scan prior to the patient's laparoscopy. The surgeon would follow up with the sonographer and inform them whether their diagnosis was accurate or not. It appears that the surgeon's feedback was a crucial factor for the sonographer's growth. While it seems that ultrasound can aid in the diagnosis process, it seems unattainable to train all sonographers by this method. All of the patients in the studies we researched were already scheduled for laparoscopy. This indicates that these patients had been through significant testing previously. More research needs to be conducted focusing on training methods in order for more general sonographers to be able to effectively aid in the diagnosis of endometriosis. Research with sonographers who do not receive direct feedback from surgeons needs to be conducted. This way, a larger group of sonographers can become more proficient with the endometriosis identification.
All right, so as Ashley was saying, we just don't think it is practical for everyone to be able to have this in-depth training. It takes a lot of time and effort, and just for kind of everyday general sonographers, it doesn't seem obtainable, especially when it comes to certain areas. Certain areas we're good at looking for dye nodules, and certain areas not so much. So what we recommend is just focusing on 3 specific areas, looking at the pouch of Douglas, the bladder, and the rectum and the rectosigmoid segment. So we'll start off with the pouch of Douglas. So the pouch of Douglas is a potential space that is between the posterior wall of the uterus and the anterior wall of the rectum. It's lined with peritoneum and is continuous with the rest of the peritoneal cavity. This is the place where free fluid often collects and is a place that we already routinely look at when we're doing our pelvic exams. So what can happen with endometriosis is that it can cause scarring and adhesions in this area. So where you've got two different walls, what can happen is the scarring can happen and those 2 walls stick together. And this is called pouch of Douglas obliteration. So in order to assess for obliteration, the sonographer can use the sliding sign, same as we were talking about with the ovary. The sonographer applies pressure to the cervix with the internal probe and then watches to see if the wall of the uterus and the wall of the rectum slide independently from one another. If they are adhered, they'll move as one, and the pouch of Douglas obliteration is proven. This is just a short extra step, but it can be really a strong indicator of endometriosis if this obliteration is proven. Next, we'll talk about the bladder. So normally when performing an internal ultrasound, we get our patients to completely empty their bladders, as empty as they can go. But what we would ask them to do is just keep a little bit of urine left in their bladder so it can outline the walls of the bladder a little bit better. This just allows us to identify dye nodules that was infiltrating the bladder walls. Just gives us a better outline. So how we would do that is we would place the transducer in the anterior fornix, which is just as close to the bladder as we can possibly get. And then while we're assessing, we can also use the sliding organ sign again to see if the bladder wall and the uterus are sliding independently from each other. If adhesions are present, again, the sliding sign will be negative, and this just has a higher suspicion for endometriosis. The last area that we recommend focusing our time on is the rectum and the rectosigmoid segment of the large bowel. This is an important area because they found that 88% of bowel-related dye lesions are found in this area. So to assess this area, we now place the internal transducer in the posterior fornix, which is closest to the rectum, and then we focus our attention along the anterior wall of the rectum, just looking for, they can be quite irregular, but just irregular hypoechoic regions of varying sizes, which could indicate dye nodules. And then we try to complete a thorough assessment as significantly high as we can. Obviously, there's a lot of restrictions when it comes to internal scanning, but just as superior as you can into that rectosigmoid segment. So in conclusion, after we reviewed all the literature, it's clear that more research needs to be done in this area. General sonographers tend to have quite minimal training when it comes to identifying this disease, simply because it's hard for us to see it. And the standard pelvic exam doesn't thoroughly assess for these dye nodules. However, it was shown in the literature that if there is specific training, that we can become more proficient in identifying these dye nodules. So what we think further research should go into is just the techniques and methods for us as sonographers that don't, take up so much time and feedback. So more just figuring out ways that we can train ourselves a little bit quicker in order to identify these areas. So for now, we just believe that if we can include these 3 extra steps in the standard pelvic exam, that the likelihood of us as general sonographers at identifying this endometriosis could increase, and that would lead to better patient outcomes. So thank you for listening, and we'll now be taking questions.
Hi, everyone. My name's Britt, and this is Christina and Katie. Tonight, we'll be discussing how and when to perform MCA Doppler in obstetric ultrasounds. MCA Doppler is a pulsed wave Doppler measurement of the fetal middle cerebral artery. It's used as a non-invasive prenatal screening tool for detecting abnormalities that affect fetal circulation. MCA Doppler's most common use is for detecting moderate to severe anemia. It can be performed as early as 16 to 18 weeks gestational age up to 40 weeks. Some of the indications that might warrant performing MCA Doppler include a fetus at risk of anemia, intrauterine growth restriction with head sparing, unexpected high drops, maternal red cell alloimmunization, feto-maternal hemorrhage, and TTTS or TAPS in twin pregnancies. There are many benefits to performing MCA Doppler. One of the major ones is that it contributes to management of abnormalities by providing valuable diagnostic information from an early gestational age. It can be used to detect moderate to severe anemia and therefore used to determine if a fetus will require an intrauterine transfusion. Unfortunately, mild anemia is not reflected in the MCA Doppler, but this is not as crucial as this doesn't typically warrant an intrauterine transfusion. The information collected from MCA Dopplers can be so useful that it may prevent patients from undergoing invasive procedures such as amniocentesis. It can also be used in conjunction with uterine artery Doppler or ductus venosus Doppler to monitor intrauterine growth restrictions. In the setting of monochorionic twins, MCA Doppler can be used to help diagnose TAPS when there is not an evident fluid discordance. I'll now pass it over to Christina, who will be discussing the anatomy of the MCA and how to perform the Doppler measurement.
The middle cerebral arteries are part of the circle of Willis, which is located inside the brain. The circle of Willis is a network of arteries which provides vascular connection between both the right and left sides of the brain, as well as the anterior and posterior aspects of the brain. The main arteries that feed into the circle of Willis are the internal carotid arteries anteriorly and the basilar artery posteriorly. The MCA is the preferred artery for Doppler for a few reasons. It's easily accessible. Babies tend to lay on their sides with their heads turned, so the artery is at a good angle for Doppler more often than not. It contains 80% of cerebral blood flow. It's a nice, juicy, reliable artery to put a Doppler cursor through. It's also very sensitive to the effects of hypoxia. So how do we actually perform an MCA Doppler? We've created a simplified step-by-step guide that we hope you all implement in your own clinical practice. So step 1, you need to approach the baby's head from the side in a transverse plane. Line yourself up as if you're about to do a BPD measurement. Step 2, apply color Doppler. You'll see the circle of Willis anterior to the thalamus, and you'll see the 2 branches of the MCAs on either side. Oops. Step 3, make adjustments to get as close to 0 degrees as possible. It's important to get to 0 degrees to capture the highest velocity. Just like umbilical artery Doppler, movement and respirations can cause inaccuracies within the trace. So this is a pretty good time to politely ask the baby to stop moving, stop breathing, easy peasy. Step 4, place a 2 millimeter PW sample gate in the proximal 1/3 of the near field MCA. Step 5, acquire a trace with at least a few consecutive beats in a row. If your machine auto traces the waveform like in this picture, it's best to just turn it off. You don't want to run the risk of the machine averaging the peak systolic velocity. Just keep it simple and put a caliper on the highest peak that you see. Step 6, you need to store at least 3 traces. You should measure the highest velocity on each trace. The last step is to record the highest peak systolic velocity that you obtained and record it on your tech worksheet for the doctor. This is what will aid in the diagnosis of anemia. Katie will now explain the different appearances in normal and abnormal Doppler trace.
So a normal MCA has a high resistance waveform. There should be presence of low velocity and diastolic flow. In cases of anemia, the MCA Doppler will show an increased peak systolic velocity as seen in the waveform on the top right here. This is because with anemia, a fetus will respond by increasing cardiac output and redirecting blood to vital organs. Anemia causes blood to have a lower viscosity, and this in combination with increased cardiac output leads to higher velocities. In cases of IUGR, head sparing causes the blood flow patterns in the brain to be altered as well, as shown in the bottom right. There is a shift in the MCA from high resistance to low resistance with increased end diastolic flow. As for values, the MCA velocities tend to increase with gestational age. A peak systolic velocity of over 1.5 times the median for that gestational age is considered to demonstrate moderate to severe anemia. After 35 weeks gestational age, there is an increase in false positive rates, and this may be attributed to variation in fetal movement and respiration. In order for MCA Dopplers to become a more integrated part of all sites' OB protocols, there are a few factors that need to be considered. There needs to be consensus between physicians and sonographers. Physicians at all sites must be on board and willing to interpret and report the results, and the sonographers must be on board and willing to perform the Dopplers. Also, it would be beneficial if physicians knew they were able to ask sonographers to perform the measurement whenever indicated. Another consideration is that there needs to be a standard protocol in place for performing the measurement in order to make sure that it is consistent among sonographers. Consistency in performing the measurement is critical in implementing widespread application of MCA Doppler. To ensure consistency, BC Women's standards could be used at each site. there also needs to be clear understanding as to when MCA Dopplers should be performed. There are so many types of anemia, and therefore there may need to be clarification as to which types of anemia require MCA Dopplers. This can become very complex, and so it's important that we have involvement from both the sonographers and the physicians. So we hope that this presentation brought to light the value of MCA Doppler in OB ultrasounds, and with the cooperation of both sonographers and physicians, we think that this could improve the outcome for many babies.